Just a small reminder, asthma is a chronic inflammatory disease characterized by structural changes in the lower respiratory pathways. Severe acute asthma is defined by an intense attack resistant to standard treatments. Regarding therapeutic management, no paraclinical examination should delay intervention as it is a life-threatening emergency. Hospitalization in intensive care is crucial, and appropriate management or positioning is initiated with continuous monitoring of the patient's general condition and peripheral intravenous access for the administration of necessary medications. Oxygen therapy at a dose of 6 liters per minute aims to maintain blood oxygen saturation above 90%. The goal of the treatment is the resolution of the bronchospasm. This means stopping the sudden constriction of the airways in the lungs, especially the bronchi. For this, medication nebulization such as salbutamol and ipratropium is used. Nebulization is a method to administer the medication directly into the lungs as a fine mist or aerosol. Salbutamol nebulization with a carrier gas of 6 to 8 liters of oxygen consists of 5 mg in 10 to 15 minutes every 20 minutes for an hour. Salbutamol is a bronchodilator, acts on beta-2 adrenergic receptors in the smooth muscles of the airways. These stimulate relaxation of the bronchial muscles and inducing bronchodilation. Ipratropium also is a bronchodilator but with anticholinergic action. It is administered by nebulization with a specific dose for adults and children. The dose for adults and children above 6 years old is 0.5 mg in 10 minutes, repeated every 20 minutes. If the child is less than 6 years, we divide the dose to half and multiply it by 3. Systemic corticosteroids, especially methylprednisolone at a dose of 2 mg per kilogram as intravenous bolus, also plays a crucial role in the case of a failure of previous treatment. If there is a hemodynamic status failure, additional measures such as an adrenaline infusion tailored to each case may be necessary. In the absence of improvement, options include salbutamol via self-propelled syringe at a dose of 0.5 mg per hour, to be increased every 10 minutes in increments of 0.5 mg up to 5 mg per hour. Finally, magnesium sulfate with a dose of 2 grams in a free intravenous infusion over 20 minutes can be useful. Continuous oxygen therapy is maintained, and measures are taken to prevent relapses through bronchodilator aerosols and corticosteroids. Prevention of relapses includes bronchodilator aerosol such as terbutaline at a rate of 6 puffs per day, and corticosteroid therapy with methylprednisolone at a dose of 1 mg per kilogram per day by intravenous injection, with oral transition as soon as possible, in most cases 5 days. Treating decompensation factors such as infection is also essential to avoid any recurrence. There are some medications that are not indicated in the acute exacerbation phase, including aggressive rehydration, sedatives due to the presence of respiratory depression, mucolytics which can increase cough and bronchospasm, antibiotics except in cases of clinical infection, and long-acting beta-2 mimetics. There are cases where mechanical ventilations may be indicated for certain patients, but it is considered in severe cases, especially in the presence of an impaired consciousness. Refractory hypoxemia, defined by not responding to oxygen therapy, worsening hypercapnic acidosis, and signs of respiratory exhaustion such as tachypnea and paradoxical shallow abdominal breathing. After stabilization, monitoring the clinical conditions and oxygen saturation is important. Hope this video was helpful, and thanks for watching.